Yes, good afternoon. And so we're halfway through what I call the week of lots of intensity as far as looking at how well we're doing with our physical distancing, as well as we start to see as the numbers rise that we've noted with our laboratory testing, and we'll give you the numbers here in a moment, with the ones that came back and others that made contact with some of those about nearly 2 weeks ago, about a week and a half ago. And as those numbers increase, you backtrack, a certain percent of those will be hospitalized, and a certain percent of those will end up in ICU, and a number of those will have to be ventilated. And unfortunately, some in that time there, a certain percent, at least based on population data, may succumb to the illness. So we are seeing those other numbers go up, and we're looking at those intently with all our planning at the command table as we're doing a lot of scenario design and planning based on the evidence we're getting from various scientists and groups who have done versions of modeling and are continuing to look at the modeling and revise the modeling. And we hope to have some report on some of their projections perhaps by next week, but they keep changing and altering depending on our data, just because we're so, in the modeling projections, we're so early in the curve. So we're going to be able to talk about that maybe better next week in that regard. So with that in mind, we'll first go over to the numbers and let Dr. Yaffe talk about those, because the numbers in this time when we're getting larger numbers coming forward, more things happen every day with many sectors in different ways. The task and the logistics of pulling all those together and making sure they're exactly correct as all these new groups are being brought in, whether it's new labs being brought in, new institutions being brought in, new regional groups and new offices. This is all part of the multi-team approach here in Ontario, and that's one of our strengths we have. We have many people at the table, many people taking part, but then the coordination is one of our challenges in there, and the overall purpose in the end is to use that collected knowledge base to protect the health of Ontarians to the best we can under these circumstances. So with the numbers that we have today, I'm going to give those over to Dr. Yaffe.
Thanks very much. So the numbers as of 4 p.m. yesterday, March 31st, we have a total of 2,392 confirmed cases of COVID-19 in Ontario that have been reported in the public health information system called IFIS that's used by public health units. This is an increase of 426 cases from the previous report. We have currently a total of 37 lab-confirmed cases who have passed away. Now, there are a few things we need to note about the data. As Dr. Williams indicated, it's a complex system with many parts and players. The public health units may be publicly reporting on a death prior to updating the data in the integrated public health information system, which means that the data in that system, in IFIS, is underreported. In addition, there have been deaths that have been in outbreaks where they have not been laboratory confirmed, and they would not be included in that total. This means that cases linked to an outbreak are at this point captured separately. According to IFIS, we do know of 12 deaths related to outbreaks in long-term care facilities. Some of these have been lab confirmed, others have not. Now, on a go-forward basis, this will not be an issue because the new directive that was issued, I guess now 2 days ago, for long-term care homes is that all symptomatic individuals, both residents and staff, will be tested. So all cases will be laboratory confirmed. We continue to see the number of resolved cases increase. At this point, we are at 689, which is almost 30% of the total. In terms of hospitalizations, right now we have a total of 332 patients with COVID-19 in hospital in Ontario. Of those, 145 are in the intensive care unit, and of those 145, 98 are on a ventilator. The laboratory testing continues to improve. and the capacity is going up. At this point, we have tested almost 58,000 individuals in Ontario for COVID-19. In the last 24 hours, 6,245 people were tested, and the backlog is down to just over 3,100. And we do anticipate the capacity to increase more over the next few weeks. Thank you.
Right, and it's anticipated that our capacity will continue to increase in the labs as we go to the end of the week and up in next week, trying to move beyond 15,000 a day, perhaps up to 18,000, as we bring more and more laboratories on, both hospital-related, other laboratories, and community-based laboratory systems in there. And part of that is the richness we have with those many different labs that are now ramping up and taking part with adequate supply at the moment of reagent and test kits in there. But of course, we have to keep getting procurement and move on that. That means our capacity will increase, and also the proximity of some of those labs to some of the centers, be they long-term care centers, acute care hospitals, or other ones that we are hoping to do in a systematic way to get the lab tests even more expeditiously out, and to do that in a way so we can consistently have the data flow back into the center and coordinate that so we have the correct numbers. As you can imagine, that has its challenges to do that in an accurate way, because all these ones in the busyness of doing their process of lab testing, they have to do all the data collection, all the collation, and putting those in timely manner, both to report to the local ordering physician or entity, the local health unit, and then up to the center to get those numbers in there correctly. So the challenge is the coordination. The benefit is that we have that many out there operating and ramping up even more as we speak and we go into next week on that. And I guess that's one of the things in that today we're mostly emphasizing. As I said yesterday, when we are going through all these lab tests and we're seeing what happened basically 2 weeks ago, just under 2 weeks ago, and we're going through this time when that week of the 16th of March where there's so many people were coming back, and we're dealing with the tail of that and watching that. And as I noted at the outset, with those large numbers here, sometimes in the next 4 or 5 days, some of them will be hospitalized and some of them may be going to ICU and be vented. So it is not unsurprising to us as we watch carefully from our command table through Ontario Health and with our critical care group to see how the usage of the hospital beds, the usage of the ICU beds, the usage of ventilators, what is the residual that's left over, how much space. And even though we know we have residual at this time to handle, that's not satisfactory, because we want to look at the projections based on our experts who are telling us on various modeling tools what we might, could, or should expect in the next week or two in there. And so there's many contingency plans being undertaken by other sectors of the command team that are working also with local institutions as well in the regional levels, as well as centrally with various aspects within the government to ensure a timely and an adequate response to what we might face. Of course, with the hope that we may not, but we have to plan for those scenarios and do it accordingly. And that's one thing that I want to emphasize that while Dr. Yaffe and I get to come and talk to you once a day, we do that with a collation of the work of a large team. And so that's one of the things about Ontario. We do a team approach in this whole aspect. And while it's not one spokesperson, sometimes we bring 3 or 4 people up here. We've done that before. And that's what we like to show here, that this is a team approach. And we have big teams. And that's one of the wealth of Ontario, that we have many gathered around our command table, many on our other sub-tables to that, and I'm talking many as in the hundreds that are doing analysis and aspects and relating, corresponding with the public who are of concern, because we want to keep you informed and deal with the many components therein. We're starting to ramp up on some other issues there, trying to deal how we might work better with our federal counterparts as other provinces are struggling to deal with issues. One of the main ones always is personal protective equipment, and we are getting more and more encouraged with some of the aspects coming in, different ways we're trying to deal with the short-term, any concerns, and then with long-term planning and building up stock piles as well as capacity in the future in there. As well, we're trying to look at how to best coordinate with case contact management. How are we going to increase the capacity of our local public health units to do even more intensity on that in the future as we go ahead? With our lab testing going up in capacity, we're looking at now who should we test beyond our current list, making sure the priority ones are still done in a priority time fashion, and to do it well and do it timely and do it correctly. So that's moving ahead as we speak. Then with our counterparts across the country, each one struggling with the impacts that the COVID-19 is having on their vulnerable populations, and most specifically around our long-term care clients. And I've had many conferences and discussions with the deputy and staff and the minister of long-term care as we're all together on a team approach saying, what can we do, what more can we do, what should we do, and not satisfied just in case you have one or two and it gets better and you clear out. We want to make sure all the long-term care facilities are adequately resourced with the new directives sent out to them. Can they implement all those things? If they can't, how do we help them on an urgent basis to make sure they can do everything they need to do as we continue to ramp up the supports and care and dealing with a vulnerable population that is harder to track at times because of their comorbidity and their age to see if they do have overt symptoms of COVID-19. Again, worried about them and worried about the healthcare workers and the staff who devote many hours to not only giving them care, but making it like home and a place for them in that stage of life. So with that, I'm going to open up for questions and to see what Haley has online, because all the line questions.
Sure, we're going to move to the first caller.
Your first question comes from Scott Lightfoot with CTV News. Please go ahead.
Question for Dr. Yaffe. You touched on the fact that there's a discrepancy between what the health units are reporting and what you folks are reporting. And I understand it is a complex system, but my colleagues totaled up the numbers this morning. This is at the same time that you folks put out the 37 number. And if you total up the health units across the province, you actually get up to 68 deaths, which is 31 more than what the province is saying. I understand there could be a discrepancy, but this is almost double the number of deaths that's being reported at the provincial level. Can you explain why such a vast discrepancy?
Well, I am kind of surprised at that discrepancy, I have to say. We are using the data that the health units put into the database in IFIS as of yesterday at 4 p.m. That's the data that goes up on the website this morning at 10:30. And as I said, that was 37. Now, as I also mentioned, there have been in IFIS 12 deaths related to outbreaks of long-term care. And because some are lab confirmed or some are not, it's not clear how many of those 12 are in the 37. But even if none of them were, which I'm sure some of them are, 37 plus 12 still doesn't make 68. So I'm not sure how to explain that. I think as we move forward, we keep making it better and improving the system. And as I indicated, now that the directive is that if there's a case of COVID-19 in a long-term care facility, everyone with symptoms will be tested. So this potential confusion around numbers will be lessened.
Follow up?
Just to follow up, is there a better way in terms that you would see in terms of reporting these numbers, with the individual health units reporting their specific numbers and you reporting the provincial numbers? Is there a better way to streamline that information so there isn't confusion amongst the public?
Well, I mean, I personally don't at this moment have a better way. I have spoken to the health units. We meet regularly with the medical officers of health about the critical importance of putting the data into IFIS as soon as possible. So I realize they're very busy and there's a lot of things happening, and putting data into a database doesn't feel that important, but it is important so that we can be as up-to-date as possible and as transparent as possible, and that's what we all want.
Next question.
Your next question comes from Allison Jones, Canadian Press. Please go ahead.
Oh, hi. I wanted to ask about contact tracing. With the increasing numbers of cases that we're seeing, how are public health units keeping pace with contact tracing? And do you think that we're going to reach a point where we need to start using technology like some other countries have to keep tabs on those patients and their contacts?
Yes, thank you for that. And this is a concern of ours. We have been quickly asking our health units to say, if we go up with this kind of case contact management, which is what we're hoping to do, because even if we were able to flatten the curve, the real grunt work of the public health really then kicks into gear even more, where all these cases are going to have to do a lot more contacting them, doing more phone calling, more investigating, and you're looking at the numbers there, and we're asking our health units, how might or should we do this one as we face this, including we may have more work to do if we deal with, in a more assertive way, with those who are returning from outside Canada, and to monitor their home quarantine, if you may. So this is a matter that we're trying to address. How would we add extra resources to them, both technological, as in IT, information systems, phone systems, other communication systems, other staff, other groups of volunteers and different things. We're trying to address that to say each health unit, because when you see the numbers across, some, as mostly around the GTHA, have a large number, and some outside have some significant numbers, but some have very few. So they're not all the same need at the same time. So we're looking at quickly how to ramp that up, not only for today, but tomorrow and in the future, because this is going to be very important in the days and weeks going ahead. Even if we were able to flatten the first wave, there's a lot of that action that has to take place throughout the whole spring into the summer to monitor and follow those ones, so you don't get I guess like a forest fire analogy, flare-ups, because that's that work even after the front goes through. You have to do a lot of going around and putting out those hot spots and stuff, because if you don't, they can flare up and you got back into the same situation again. And that is very much intensive and takes a lot of staff and time. So we're really looking at to ramp up the resources at the health unit level so we can invest in that and to make sure they're engaged and ready to take part and do the whole package. And so it's a good point you've raised. Technology, we're going to use what we can, the technology. We're using that to give a sense of some other measures in there. I know what people do with the web-based and cell phone matters and that. We do want to make sure that we connect with the people. We're using our self-assessment tool already, and we may want to build on that and use that more. So we're always looking at different ideas. We have many proposals coming in, and nothing is being rejected outright. We want to see if it might help us in that, including the time it might take to implement and get it into place. So all things are possible with these challenges ahead of us, and we have to go full force into it.
Follow up?
And just quickly to follow up, is your recommendation today to the local medical officers of health that they use the Health Protection and Promotion Act powers to require the patients and their contacts to self-isolate? Is that going to increase the contact tracing load on public health units?
I don't imagine it will, because those ones are already being monitored by that. We've already, if they're a positive case that's supposed to be in isolation, what we're trying to deal with is that we hear some reports where individuals, for various reasons, not because it's essential in that, because they help and support, choose to ignore. We've already had some have issued Section 22 orders, as was in the Health Protection and Promotion Act, and that's a warning that this is not a casual thing. This is a serious issue, and we want the medical officer of health to use their powers and authority. That's one of the strengths we have in our system here in Ontario, to engage in that and to apply those to those individuals. Not many, but there's few who choose to do that, and they have to know this is a serious issue and it's not taken lightly.
Next question.
Question comes from Rob Ferguson, the Toronto Star. Please go ahead.
Hi, Doctor. I wondered if we could get a little bit into the modeling. Premier Ford earlier created a bit of a stir when he said the models are kind of divergent right now, and if they released one that overestimates, it could create a panic. So this is going to worry a lot of people. Yesterday we had the United States release those modeling numbers of 100,000 to 200,000 deaths. What's the range where Ontario could fall right now?
And you know that discussion yesterday had 100,000, 200,000, then I heard 1 million, 2 million. So when you're doing this type of modeling, and we've asked our scientists, and we have a group looking at that, and I have one of my staff who's a PhD in epidemiology as well looking at it. When you're on the start of I don't want to get too technical here. It's a logarithmic scale, and that means it moves up exponentially very quickly. And in those early steps, if you move it just a slight percent here and there, you go from, like the States, 100,000 to 200,000. And we want to be a bit more exact than that. That means as we get more data coming in and we get further up the curve a bit, we can get more accurate projections from our modelers. As I said at the outset, we're hoping to get something back out by next week, that we have we have another full 5 days of some data and equips them with a bit more to say which projection are we on. Are we on an Italy type projection? Are we on a South Korea type projection, or somewhere in between? And so we're really asking them to, if they can be a bit more concise, and I think what the Premier's concerned about, that you can go, like same with the States, huge sweeps in numbers, that if you don't put some credentialing on it and some aspects that allow the public to say, is that a realistic one, or what do we, because it can confuse people if you jump around between numbers and you're throwing out big ones and the next time you're going down to small ones. So we would rather not confuse the public, but we do want a plan so we have adequate to meet the different scenarios in there. So stay tuned. We hope to have something next week.
Follow up?
And just to follow up, you will be releasing that publicly?
We hope to have something to release publicly. I've been looking forward to having something like that and to show the context of our planning and how we're preparing.
Next question.
Your next question comes from Jessica Smith with Queen's Park Briefing. Please go ahead.
Thank you. I was hoping to ask if you could clarify a little bit about what the province can do with the Health Protection and Promotion Act. You've asked for local medical officers of health. Is it possible to do a province-wide order to have the same effect?
One of the unique things about Ontario with the Health Protection and Promotion Act is that, unlike any other province or territory in Canada, where all the public health is operated under the responsibility and authority of the Ministry of Health, we have at the moment 34 independent and autonomous, relatively speaking, boards of health that have the responsibility to deliver the public health programs and services in their respective jurisdictions. They then hire a medical officer of health who is a provincial offence officer that, while being recognized by myself and by the minister, the medical officer of health doesn't directly report to me, they report to their board of health, and that's part of the responsibility. So while that has more complexity with the 34, it means that sometimes the medical officer and the board of health have much better capacity to understand the issues in their local jurisdiction and deal with those matters, including if they have to write orders, 22 orders, where sitting down here in Toronto, I may not know exactly who I should write an order on, for example, say in Sault Ste. Marie or in Cornwall, but the medical officer in those situations would understand that in the context of it, because when you're writing those orders, you don't do it casually. You want to make sure you have your evidence and information appropriate, and you want to have said you've tied the other message. You've done the education, you made the awareness, you've had the discussions, you had the monitoring, and if the person still seems recalcitrant to that kind of activity, then you go with an order. And having been a local medical officer for many years, I didn't issue many Section 22 orders because I didn't take it casually, and I wanted to make sure that all the other things in public health, as I said already, were addressed first, and I expect that the medical officers locally will undertake to do so appropriately.
Follow up?
Yes, and thanks. And to follow up, I think you mentioned earlier that some 22 orders have been written. Was that in the context of COVID-19, and can you elaborate on what circumstances made that necessary?
I know of one where it was COVID and the medical officer of health had said the person was supposed to isolate. The person said they had isolated, and then they found information from another source, a reliable source, that the person hadn't. And it didn't seem that individual was taking the matter seriously enough. And so they wrote a Section 22 requiring them to adhere in that, and with the possibility of some further legal action and potentially fines, et cetera, in that regard. So I know of that one, and it was a COVID-related one, and that's the general context. I can't go into any more details on that.
Next question.
Your next question comes from Sneh Dugal with Queen's Park Briefing. Please go ahead.
Hi, doctors. Thanks for taking our questions. I was just wondering, you issued some guidelines a few weeks ago regarding essential visitors in acute care settings, including, and this would include women in labor. I'm wondering if you could clarify that recommendation. Was it that hospitals just allow the one support person in to accompany a woman in labor, and how much is kind of left up to the discretion of hospitals in this specific scenario?
Okay, thank you. That was a guidance document when we wanted to limit the number of visitors coming into the acute care hospitals, and then it actually added more stringent screening of those visitors therein. So that document is a guidance document, and that said, while they need to limit, there are some times they're going to have to be, I think, sensitive and ethically principled as far as dealing with people and unique challenges. The one wasn't letting pregnant people in labor visit. They're actually patients. It was more the family member or someone who was going in with someone whose partner was having the baby and they wanted to be there. We wanted to give enough latitude at the institution because they're all uniquely different. They have their own issues and challenges. The hospital or the center may be in different levels of closing down because of an outbreak or potential concerns that were not there 2 days ago, but they're there now. And so I didn't want to prescribe it right because I wanted to leave the administration and the healthcare professionals at the institution to use their better judgment on decide who they should allow or exempt from it at that time, perhaps with some proper personal protective equipment on, or for certain periods of time, or in certain rooms in certain areas. Those kind of details, of course, I would have no idea what's appropriate, but they certainly do, and I think they only want what's best for the individual there, the patient, and of course for the care of their institution, including their patients and their healthcare workers.
Follow up?
Yeah, so I'm wondering, I mean, we've heard from some women who are scheduled to give birth in the next few weeks who are concerned about the fact that they're being told right now they can take one person in with them, but what if this changes, and what if they're told that they have to go in alone? We saw this happen in New York with a few hospitals. That has since been overturned. But as things stand today, do you plan to suggest any further restrictions when it comes to women in labor and the individual or individuals who can go in with them? And would you step in if a hospital does decide to go that route where they say that, we're not going to let anyone accompany the woman?
There's a fair amount of ifs in there, and that's predicting and what might happen there. I think at the moment we're trying to be sense of that, and in the good old days, only one person was allowed in anyways. So that was the rules then, and only for certain times. I'm not sure they're the good old days, but they're the days. And I think they're going to exercise and still do that judiciously at this time. If there was something very much that was happening in that hospital, say there's a large outbreak within there and the chance of infection being transmitted, and they're trying to control and monitor it and understand that, the hospital may want to take some steps, depending on the advice of their infection control committee, to really get limiting. And those would be pretty unusual circumstances in that regard. But fortunately, we're not there today. And I guess we're going to have to face that if it comes up at that time. But again, we're going to be advised by that institution and what circumstances they're in, working with, of course, at the regional Ontario health level to see if there's other ways to deal with it, because maybe the person, because of circumstances, should have the delivery in another fairly close facility that might be safer for all around. There's things that you can do to deal with unique challenges.
Next question.
Your next question comes from Jeff Gray with the Globe and Mail. Please go ahead.
Hi, doctors. I wanted to ask a question because I thought I heard Dr. Davila in Toronto today say that she had issued, I think she said, a class order under the Health Promotion and Protection Act to keep people in self-isolation. Can you explain, is that something different than what you were talking about? It sounded like you were talking about an individual.
Right. So I'd have to ask her how that applies in that situation. Under the Health Protection and Promotion Act, having worked at the local level, when I'm doing Section 22s, I have to name a certain agency or entity or an individual in that. I can't put it out for a wide group. If it's a class one, it may be a large group, but then you're going to have to do some of the proper legal paperwork in that regard. So I think we'll have to let their legal counsel discussed that, how that might be applied in the City of Toronto in that, and using the Health Protection Promotion Act accordingly. But I haven't yet not been briefed on exactly how that's going to be undertaken by the Medical Officer of Health in Toronto.
And I just follow up maybe on the issue of the list of businesses that have been allowed to stay open. The Premier suggested today that that's under review and that might be some more restrictions coming. Are you recommending some other businesses, maybe construction sites or something, shut down?
We have our members working on that committee, and we're getting feedback on different aspects and getting input from not only from myself as necessary, from our wider team group, as I talked about in my preamble. It comes from many sources that feed into that discussion as we proceed forward in that, and as we compare ourselves with other jurisdictions and to see what is, quote, essential and how best to do that. And are we convinced that even those that are staying open, are they doing what they can do to continue doing the physical distancing in an appropriate way? If they're failing to do so, then the further considerations would have to be put into effect if they're unable or unwilling to comply with that direction.
Next question.
Your next question comes from Kenyon Wallace with the Toronto Star. Please go ahead.
Yeah, hi, everybody. Thanks for taking my call. I know, Dr. Yaffe, you mentioned the discrepancy between the death count that the province is putting out versus what the public health units are putting out. So I was just wondering, does the province have any plan to help make it more timely in terms of the province's numbers?
Well, I mean, it's a big challenge, and we're working on it constantly. I think that part of it will be adding some resources to the local health units to do more intensive contact follow-up and more timely data entry. And so that we can then, working with Public Health Ontario, have more up-to-date data, more complete and up-to-date data.
Follow-up?
Yeah, you also mentioned the number of patients who are currently in hospital with COVID-19, as well as the number on ventilators and in intensive care. I'm wondering, do you have the updated numbers also on the number of patients who are suspected to have COVID-19?
I don't have that data, but we're working with the other parts of the ministry to look at that data, because it's hard to understand why there are such a high number of so-called suspected cases when we know that people who are hospitalized with acute respiratory infection are a high priority group for testing. And they are a very high priority group for testing, and they should be tested. And so they shouldn't really remain as suspected. They should either become confirmed or off the suspected list. So that's a number that we need to still clarify.
Next question.
Your next question comes from Kate Allen with the Toronto Star. Please go ahead.
Hi, doctors. Thanks for taking my question. I know we come back to this question a lot, but I'm still hearing a lot of confusion from the public about whether or not they can or should go for a walk. And Dr. Davila included that in the very short list of things, or short list of good reasons to leave the house. But I have heard from people who are confused about the province's recommendations and whether parks being open for walk-through access means you can walk through it just to go to the pharmacy and get your medications, or whether we should, in fact, be going out for walks. And I think there's some compounded confusion in Toronto because, we're being told to go outside, if we go outside, to stay 2 meters away from everyone. But in a dense, downtown urban environment, it can sometimes be hard to find places where you can do that. So I'm wondering if you can clarify, are you not just allowing but recommending that people go out for walks? And can you help Torontonians interpret that advice, given the dense environments that we live in?
Okay. And yeah, I've heard that. I've had people asking, individuals asking, emailing, to say, what do we mean on that one? How much is permissive? How much is allowable? What is forbidden in that area? Because some neighbors and friends are interpreting it very down to some letter, no, you can't go out. I think what we were really trying to do is to make sure that the physical distancing is maintained in your activities. And we found some where going out and going into large gathering areas where it was pretty well impossible to maintain the physical distancing. And so they did some steps to reduce the parks, and especially these known large gathering centers that were a problem, especially as the weather's getting better and people want to get out. We want to be sensitive also that while we're asking people primarily to stay home, because it's easier to maintain the social requirements and its physical distancing, in that we know that as we're going to week 2, week 3, and going on, people do need to have some ability to not get what we call cabin fever and that kind of stuff there. And of course, physical exercise is important. The health is important too. Our only recommendation, our main recommendation, if you're going to do so, think about it, plan it out. If you're going to go out, or yourself or with your children, you're going to go out at a time when you can keep that physical distancing, and I think you're correct. With the dense urban settings, there's more of a challenge there. That includes the corridor, taking the elevator down, different aspects there, and then where do you go in there? And we're trying to leave some green spaces open so you can go there. There's concerns about the play equipment because it was not able to keep it clean. And some were concerned that that could be an actual ongoing source of transmission. And so that was probably unfortunate for some of the smaller children who would like to do that, but you can always bring some of your own toys with you. So I think if it's a planned event and you go at times when it's not busy, plan your exercise, your jog when it's of course, still safe for you in different hours, but when there's not crowds around, and your route accordingly, not to the most popular busy spots. So I think I agree with Dr. DeVille on that. While we're not saying everybody get out and do it all the time, try and stay home. Try and keep that distance up in that sense all the time. And if you need to get out for essential things, yes, you should go out and get those. Even when you go to the store, do the same type of discipline. And I'm very impressed with the number of stores that are doing that and various ways to handle that so that it's done in a very, I think, a civil way. People taking their turns and doing that. So all these things are planned out and timed, and with the concept totally of trying to maintain your physical distance.
Okay, brief follow-up.
Dr. Yaffe, I had asked you earlier this week about probable cases, and Toronto Public Health and some other local health units are now reporting their probable cases as well as their lab-confirmed cases, and combining both. At least Toronto Public Health counts both towards their total cases. And we've spoken to researchers who say this is an important number for understanding the true burden of illness in the province. So I'm wondering again if the province will report the probable cases going forward.
Well, and until we know that all the health units are actually counting probable cases and inputting them into IFIS, we would not be able to count them because it would not give us a complete picture. The other thing is probable cases generally are people who have the signs and symptoms, may have a travel history, whatever, but have not been tested, or the test came back indeterminate or inconclusive. And I think as the lab capacity goes up, there will be less probable cases. That is my hope. So, it's good that the health units have decided those that are entering the data to put it out, that's fine. But until they're all entering it, we really can't put it in.
Next question.
Your next question comes from Laura Stone with the Globe and Mail. Please go ahead.
Oh, hi there. Dr. Yaffe, I just wanted to ask about your remarks off the top about increasing testing and how that will change figures coming out of long-term care. I was wondering if you could just expand on your recent directive to increase testing in long-term care homes, why you decided to do that, and how you think it will impact the up-to-date numbers going forward.
Sure. Well, actually, the directive was from Dr. Williams, but that's okay. I'll explain it.
I'll let you answer.
Thank you. Thank you very much. What we're seeing, certainly in the States and starting to see in all parts of Canada, is that, as we know, residents in long-term care are a very vulnerable group for a variety of reasons. They tend to be older. They tend to have comorbidities, other underlying illnesses. Their immune system may not be what it used to be, and they're living in a congregate setting. That is their home. And so we do see outbreaks, and we see very serious outbreaks that spread quickly with a lot of illness and, unfortunately, death. So We were using the general infection control guidelines that we have always used for respiratory infections, which we use for influenza every year. And those were basically that you would test up to 4 people on in an institution. If they all came back with the same organism, let's say it was influenza or another virus or whatever, you'd say, okay, anybody else who fits the case definition who has those symptoms, that's what they have. It's called what we call an epidemiologically linked case. So you don't need to do the test. So what we're seeing, though, with these outbreaks is we need to really get a better handle on who's infected and making sure that the strongest possible measures are in place. So the directive, one of the things in there was that when you have one suspect case, and that's one of the things, just to look for those symptoms is a challenge, particularly in seniors, in elderly people. They may not mount a fever. They may have a lot of other symptoms, and they may not have obvious symptoms. Any change in their health condition, really, it's important to say, okay, let them get tested for COVID-19. And if we have one positive case, we call that an outbreak for COVID-19. And it's important to test every other person in that facility, resident or staff, who have the symptoms. Not just 4 and say the rest are assumed. We're going to test everybody who has the symptoms so we get a better picture of all the cases and make sure all the preventive measures are in place, the control measures. And there's lots of other things that came through in that directive around screening of staff, screening of residents twice a day, including temperature, a lot more infection prevention and control, use of PPE, cleaning, communication with the families, and it's a very comprehensive directive, but the testing was one part of it.
Follow-up?
And just on another topic, just regarding flights that are coming home, I'm wondering from a public health perspective if you think that we should be bringing Canadians who are overseas back home right now, given how many flights have had confirmed COVID cases since March 13th.
So you're talking about the flights as compared to cruise ships and that. We, unfortunately, even after we did things, some people were still out and traveling. And I think the whole COVID-19 global perspective caught a lot of them off guard. At the same time, they are Canadians. Their systems are here, their health system, as well as their physician or healthcare communities back here. I think with our method, with the the federal quarantine order, and by handling that, and we're trying to set up a good method to do that in a robust way here in Ontario in partnership with the federal authorities, and if they would come back, and assuming if they're going to fly, there should be asymptomatic when they board the plane, and a lot of countries are not allowing symptomatic people to board the plane. If they do come back asymptomatic, they are required by law to quarantine for 14 days. In that time, and if in that time they become ill and get assessed with COVID-19, then the quarantine period is extended further. So I think with all those steps in place, if everybody, the returning Canadians are as responsible as those back here, will carry out their duties and responsibility in an appropriate and civil way, and to maintain that. If not, of course, there are some legal repercussions if they fail to do so. But again, that's a last resort. We hope they will do the right thing as they feel the safety of getting back into Canada, and then having access to health services in a timely and effective way, so that we can make sure if they do develop COVID-19, we'll give them the best care we can. And of course, we want to make sure it doesn't spread to other family members, especially the larger family and some of the vulnerable members in their community. So I think we still have a responsibility in that way, and the Prime Minister has said that. But there are limitations as countries are closing down and airlines are closing down, and it may not be that easy for people to acquire the transport to get back in the country here.
Next question.
Your next question comes from Afua Ba with 105.9 The Region. Please go ahead.
Good afternoon, and thank you very much for taking my call. My first question is regarding hearing a petition about international medical graduates as well as recent Canadian medical graduates that they say they're willing to help. And we know that there is an increased pressure on current frontline healthcare workers. Will there be any sort of recommendation in order to maybe allow the recent Canadian medical graduates and international graduates to work alongside the healthcare workers right now that are currently facing the pressure?
Well, thank you. And we have, as I said, with our big team at the command table, we have a whole group that's working on human health resources in that, and that looks at all the different groups that might be available, from volunteers to international medical graduates to medical students to various components in there. That how do we facilitate respecting existing regulatory colleges, etc., other work conditions and agreements with various organizations to be able to bolster up that. At the same time, we don't want to put them in situations where their training as such is not suited to an institution that may have specifically trained staff, but there are other things that they can do in those various settings that could free up some of their staff to move into those other areas. And again, we don't want them getting involved in those and putting them at risk. We want to make sure they're fully trained, so they're doing proper use of personal protective equipment in that. So while we respect the volunteerism, and it's been quite I would say quite encouraging, the number who want to come forward, but we want to make sure in that we're not putting anyone inappropriately in harm's way without the proper training, education, and protection. So these things, while we don't need it right today, we want to prepare as if we will need it and keep ramping them up. And as I said, we're already looking at how we might utilize some of the skills and ability in expanding our public health infrastructure to respond to the big challenges and workload ahead of us.
Follow-up?
My follow-up is a two-parter. So I know that there's a temporary hospital that's been being built in Quebec. There's one that is currently being built in Burlington. Would it be possible, if there is the worst-case scenario, there's right now the Mackenzie Vaughan Hospital slated to open in later this year. Would it be possible that part of that hospital could be opened up in order to maybe alleviate some of the pressure that's on current hospitals? And as well, I know that some people who have come back, who have recently traveled and are now mandated to stay at home during their 14-day quarantine, but we are hearing some who are not actually abiding by those rules. Would it maybe be better to create some sort of quarantine center, the same way that CFB Trenton created when the Canadians from the cruise ship returned, and just have those people placed there? That way they follow through their 14-day process there and then are able to go back into the community.
Okay, I'll try and remember all those parts there. On the aspect of other centers and places for patients, we have a team looking at that aspect there. We're aware of the extension tent structure that the hospital in Burlington has on their side put in place. In that, we look at some other facilities that could be utilized. Those ones you mentioned, we ask our capital group to look into those to say, is it possible or not possible? And there's a lot of factors that weigh into that. That while you want to use a facility, if some of it's still being constructed, you do not want to use one that such that it would be unsafe to put people in those type of facilities in that regard. And so these all have to be taken into account. While some may seem like heroics to undertake, we want to make sure that the settings are safe, that they're functional, and that patients, if they're going to be handled there, including the healthcare workers, are going to operate in those settings, have what they need to do, and with all the proper supports and systems in place, so they're not in any increased risk to the patient, for the patient to be at risk, or the healthcare workers. So this, while it may seem painstaking, is critical to do, and you want to do it ahead of time and not in the heat of the action. So many of those things you mentioned, we are looking at, and our team is engaged in that process as I speak here. The one about the interesting concept, and we've had some discussions about that, and we know that some of the time when you kept everybody, like in the one cruise ship, on board clustered together, that did not turn out to be a good result. And we find it's better if you're going to take people out, that if you can keep them separated in some way but still keep monitoring them is the ideal solution in that. If you're talking like Trenton and those, That's one thing. If you're talking about the people returning, even though our numbers have dropped considerably, the last time I checked on the end of March, they're still coming to Ontario was by air and road mostly. I don't think rail too much. About 10 to 13,000 a day coming in. You cannot put all that number of people in one place. Plus, if you have a better system, that's what we're trying to build with our public health infrastructure and working sometimes with our local peace officers, etc., we can, I think, do a proper system monitoring. And I think for the most part, people will do what they need to do if they found that they understood that we are concerned. We're serious about this, and they need to be serious. And we're going to help you to do that. We're not going to leave you isolated so you're in a desperate state that you can't get food, you can't get other things. And so we have to do our part as well in that. And you can imagine those numbers. It's not inconsequential. And so that's going to really demand upon us and our peace officers in different function working in conjunction with our federal authorities to do it well. But I think some in their own home setting could do it much better over 14 days if they really understood the need to adhere to it, and they knew that we're monitoring that situation and trying to assist them in that regard. If you put them all in one center together and cluster them close, it'd be a huge facility and facilities, and then they haven't got all the infrastructure they need, and there's all the cost that someone has to pay for running those centers in there, whereas the person has a house on their own where they could do that at no extra cost to the public. So these are all things we weigh out in there, and even the federal government is thinking maybe that they would choose to have them in their home setting rather than in an institutional setting such as Trenton or the NAV-CAN Center.
Okay, thank you. We're moving on to the next question, and that will be our last one as we're close to being out of time.
Your final question comes from Jennifer Byman with London Free Press. Please go ahead.
Hello, thank you for taking my question. I was speaking to a medical officer of health today in Sarnia, and they have an outbreak at a retirement home, 11 cases linked to that place. Now, she described sort of a gray area about how public health can handle and report and manage those kinds of things because, retirement homes are not, long-term care facilities. They're sort of independent living spaces and things. So I just wanted to know, you guys have done a lot with long-term care. Just want to know how the retirement home piece sort of fits into those plans.
Well, that is an excellent question, and we've been discussing that with our Ministry of Seniors, which is the ministry that has responsibility for the retirement homes. And as our retirement homes have enhanced and flourished over the last number of years, and the number of people residing in those, it's still in the concept. These are people who have they have paid for their apartment. 1 or 2 bedroom or whatever. They have their independence in that. They're used to coming and going. Some have their own vehicles. So it's in a way, like an older person's condominium. And so we're trying to respect the right that these are individuals living in those supportive services where they might have some common food services. They have usually cooking facilities in their own apartments, and they can undertake to do that. Some engage in some joint activities, some don't. So it's like a communal type living situation, still respecting that these are people living independently and are responsible in a way for their own health and their own care. In that, usually still they retain their own health care provider and go out and visit and see them. We've seen a certain sense of as the some people from long-term care, by lack of space, have gone to some of those areas, and some do require more health care. So this is a new challenge we face in the sector. We're trying to understand if we have to make any changes, and I have some of those things in the actual directives I gave out that alludes to the retirement homes, and that was upon the request of the Association of Retirement Homes, that we would try and have a more I would say, comprehensive engagement with them, and that's a new territory for public health. We haven't been asked to do that because, I said, these are much like independently living citizens, but we have a sense from the course with COVID-19 and their vulnerability that we have to move alongside and see what we can do to assist to prevent, as you noted there, outbreaks in these communal citizen areas with seniors, and many, while they're living independently and quite mobile, are well on in years, and that's to the credit of their of the healthcare system, but it doesn't mean they're not out of the risk category. So we're trying to do that live time as we move alongside and assist during these unique and very challenging times.
Okay, follow up, and this will be the last question.
Are you able to say how many outbreaks you've got in Ontario right now, both in long-term care facilities and retirement homes, even though the retirement home piece is still getting kind of figured out, or at least navigated?
Well, as I...
long-term, I'll do retirement.
Sorry?
You do long-term care homes, I'll do retirement homes.
We're aware of, as I said before, 12 outbreaks in long-term care homes. I wouldn't be surprised if there were more, but that is the data as of the IFAS data from yesterday at 4 o'clock.
Okay, thanks very much.
In the retirement homes, the last time I looked, there was 6 that were looking at suspected retirement home outbreaks. That list is changing, as you may see, and sometimes what we're trying to do with the long-term care homes, as Dr. Yaffe already said with my directive, the first time of someone with symptoms, even though you haven't got identified cluster, we're doing the part of declaring an outbreak right from the get-go, that we may say, oh, okay, it wasn't a false alarm, but that's fine. As I said, I don't mind false alarms, but that means the numbers you might see may be quite larger as they go through that initial phase of saying, is it really an outbreak, or is it some other illness? Is it another viral illness? Is it influenza? And it's a different thing altogether. And so it may be an outbreak, but it may not be a COVID outbreak in there. But we want to ramp up the sensitivity to raise the alerts. That means those number of outbreaks by the numbers or by the classification will go up just because we've widened the definition.
Okay, thanks everyone.